All right, so let's talk about seizures today. Thank you, as always, for the really nice comments, the new subscriptions, everything. Thank you so much for the support. I really do appreciate it. Let's go ahead and get started with seizures, following on with the neurosystem. So let's talk a little bit about what seizures are first, just to give you a general understanding. So seizures are a sudden change in behavior caused by electrical hypersynchronization of neuronal networks in the cerebral cortex. So what this means is neurons are all synchronously active. They're all firing together when they're not supposed to be. So whether this is caused by too much excitation, caused by problems with the NMDA receptors, too little inhibition with defective GABA receptors, the effect's the same. You have all these neurons firing inappropriately, nonstop, which causes a number of clinical manifestations we'll go over. So just a general understanding about that. Now let's talk about some causes. The way that you remember the causes, not that you necessarily have to memorize all of them, but just to kind of know what things can cause seizures, is to remember the word vitamins. So what does vitamins stand for? The V stands for vascular, so like vascular malformation, stroke. The I stands for infection, meningitis, encephalitis, trauma, of course, traumatic brain injury. Autoimmune, think lupus. Metabolic causes would be low blood sugar. Most low electrolytes can cause seizures, so hypocalcemia, hyponatremia. Ingestion, so whether this is ingesting toxins like drugs that can cause seizures, or withdrawal from ingestion of certain toxins. So withdrawal from alcohol, for instance, can cause seizures. The N stands for neoplasm, so brain tumor. And then the S is the second letter in psych, because you can have psychogenic. They're non-epileptic seizures, think conversion disorder. So those are just some of the main things to kind of think about in your head when you're thinking seizures and what may have caused a seizure. So moving on, let's first talk about epilepsy, because we're going to be going over epilepsy a lot. We're going to be throwing that word around a lot. So just to understand what epilepsy means and how to kind of make the diagnosis of epilepsy. So there's some criteria to meet. In general, epilepsy just means you've had more than one seizure, but there are certain criteria that fits it as well that can also mean epilepsy. So when you're making the diagnosis of epilepsy, there's a few criteria to meet, and the official diagnostic criteria is 2 or more unprovoked seizures occurring more than 24 hours apart. Unprovoked means it wasn't caused by one of the vitamins we just went over, so it wasn't like a low blood sugar that caused it or an infection. Another criteria to meet epilepsy would be 1 unprovoked seizure and a high risk of recurrence. So high risk of recurrence would be things like stroke, traumatic brain injury, brain tumor. So you can have just one seizure, and then you have a high risk of recurrence, and you're diagnosed with epilepsy. And then finally, just this kind of non-specific one, identifiable epilepsy syndrome, which is genetic or idiopathic epilepsies. So let's talk about the different types of seizures. There's focal, generalized seizures. Most seizures can be categorized by either focal or generalized according to where they affect. So when one hemisphere of the brain is affected, just half the brain, you have what's known as a focal seizure. So we can take a look at the image here. So just half of the brain, or just even one lobe, this is going to be what's considered a focal seizure. And then in generalized, we can take a look at the picture here. Generalized would be when both sides of the brain are affected simultaneously. So generalized seizures include all different subtypes, which I'll list here, but we're going to go over those in more detail in a few minutes. So those are focal and generalized seizure. Again, focal is just one part of the brain, one lobe, one half. Generalized is going to be both sides at the same time. Generalized has all of these. And then focal seizures, they can be further classified according to whether consciousness is altered or not during the event. So focal seizures with retained awareness. These used to be called simple partial seizures. You may still hear them being called that. The presentation is going to be unique in each patient with this type, because it all depends on the part of the cortex that's affected at the onset of the seizure. So if it affects the occipital cortex, it may result in flashing lights. The frontal lobe may cause sudden speech difficulties. There may be changes in hearing and taste. It's possible to have involuntary movements or jerking movements. The key, as the name suggests, is generally they're going to retain awareness or consciousness during the episode. And then you have focal seizures with impaired awareness. They used to be called complex partial. So during a typical focal seizure with impaired awareness, patients may appear to be awake, but they're not going to respond normally to instructions or questions. They may stare into space. They may remain motionless, engaging in repetitive behaviors. They're called automatisms. They can include facial grimacing, lip smacking. So their behavior is altered in some way. And then after these type of seizures, these patients are going to enter what's called the post-ictal phase. And during this time, they may have confusion, headache for up to several hours after the seizure. So those are different types. Let's talk more about generalized seizures. So again, generalized seizures, both hemispheres of the brain is going to be affected. And in most cases, most of these types of seizures will involve some degree of altered consciousness. So there's different types of generalized seizures like I just touched on briefly. The most common type of generalized seizure is going to be what's known as tonic-clonic or grand mal seizure. So this is the most common generalized seizure that you'll see, and it's basically what everybody thinks of when they think of the classic seizure presentation. So let's talk about what this is and kind of understand what a tonic-clonic seizure is. So tonic-clonic grand mal seizure. So tonic means rigidity or sudden muscle stiffening. That's the first part. So the muscles can sometimes stay contracted and stiff for up to a minute or two in the tonic phase. And then the second part is called the clonic phase. So tonic-clonic, second part is clonic. And this means rhythmic jerking muscle contractions, usually of the arms, the neck, the face. So a tonic-clonic seizure usually begins with an abrupt loss of consciousness and then followed by the tonic phase where all the muscles become stiff. Then after a minute or so after that, the muscles will begin to jerk and twitch for an additional 1 to 2 minutes, and that's your clonic phase. And this is all going to be followed by a post-ictal phase after. So that's tonic-clonic. That's the big one you need to focus on. And let's talk about some other types of generalized seizures that may come up. So myoclonic. This can involve a single muscle, sometimes a group of muscles, and it's just a brief contraction. It's just a little jerking motion. So it's a quick contraction of a muscle and then it stops. Most commonly, it's going to involve the arms. Consciousness is not usually impaired with this type of seizure. Then you have clonic, just like we just went over in tonic-clonic seizures. The clonic seizure is going to have that rhythmic jerking and muscle contractions, usually involving the arms, neck, and face. And then tonic, again, like we went over, in tonic-clonic, this is going to have sudden muscle stiffening. It's often associated with a loss of consciousness. The way that I used to remember tonic seizures and what they involved was I used to think of a gin and tonic, and a gin and tonic is a stiff drink, and a tonic seizure is muscle stiffness. So as soon as I would see tonic seizure, I'd think of a gin and tonic, remembering a gin and tonic is a stiff drink. Tonic seizure means the muscles become stiff. So that's how you remember tonic. And if you can remember what tonic means, you can remember what atonic means, because atonic is just the opposite. So atonic means the muscles basically turn to jello. So the opposite of stiffening like we saw in tonic. So these individuals with atonic seizures will have a sudden loss of control of the muscles. Commonly, it's going to be the legs, and it's going to cause these patients just to collapse. So most of the time, they're going to be conscious. While this happens, they just lose control of their muscles and they just drop to the ground. That's why you sometimes hear these being called drop seizures, because their legs just turn to jello and they just drop to the ground. So that's atonic. If you can remember tonic, as in tonic-clonic, that's stiff drink, muscle stiffening, you can remember atonic, and then you can have two knocked out right there. And then finally, we have absence seizures. Absence, I've heard it called. They were previously called petit mal seizures, and these are usually going to be seen in children. So what happens in these children, they'll be in class, they'll be at home, doing well, nothing's going on, and then all of a sudden they'll just start staring, and they'll have this state of impaired consciousness where they won't respond to any verbal or tactile stimuli. And then during these episodes, they may have eye blinking, lip smacking, and this can actually occur hundreds of times per day. Typically, each episode is going to be pretty short, between 5 to 10 seconds, and a lot of times this is misdiagnosed as ADHD. So absence seizure, no loss in muscle tone, but impaired consciousness for brief periods. No absence seizures very well. You will be tested on this because it has a unique presentation. It has a specific first-line med we'll go over in a minute. And like all unique things with specific first-line meds, they're always going to get tested on. So no absence seizure very well, because you will get a question on this, whether it's in your clinical medicine class, the PANCE, you'll be asked this at some point. Now let's talk about one last thing, I guess you could say, type of seizure, not so much a specific type of seizure, more just a seizure that just lasts for too damn long. So the official definition of Statusepilepticus is a unremitting generalized convulsive seizure lasting longer than 5 minutes, or it can be multiple bilateral convulsive seizures without a return to baseline level of consciousness. So either this patient has a single seizure that lasts over 5 minutes, or they have one seizure without recovery between each episode, just back-to-back seizures. This is a medical and neurologic emergency. Your neurons are firing nonstop. They're essentially frying their brain. You have to abort the seizure quickly. These patients need prompt treatment, and we'll go over that treatment protocol in a minute. It's another thing that you definitely need to know because it has a specific regimen that needs to be followed. So that's status epilepticus, and then let's keep on moving along here. Let's talk about diagnosis. So diagnosis, obviously, you want to start with a very thorough history. A lot of times this is going to be obtained from a friend or family member that witnessed the seizure. You need to find out, was there any trauma, any drug or alcohol use? Most patients with epilepsy are going to actually have a fairly unremarkable clinical history. And then, of course, as far as the diagnosis, you want to have a physical exam, including neuro exam, and then you start with your initial lab work. So let's talk about that. So with your laboratory tests, definitely going to do a rapid blood glucose. You want to make sure this wasn't an episode of hypoglycemia, which can lead to seizure. You want to get a CBC. The CBC, you're looking for signs of infection. Remember your vitamins there, I for in the vitamins was infection. You want to get a CMP. In the CMP, you're checking your electrolytes. You want to make sure this isn't hypocalcemia, hyponatremia, checking your renal function, your LFTs. And then you want to do a urinalysis, a toxicology screen, making sure there was no drug use or anything. And there's different things basically to search for all of those vitamins that we went over in these labs to look for a potentially reversible cause. So be aware of the different lab tests. Don't memorize like every single one. It's not going to be very useful, but just have a general overview of what you're looking for, what you're searching for here. One lab that I do want to go into a little bit more detail about is serum lactate, because you may hear about that. So serum lactate is a good lab to obtain in a patient who had an unwitnessed transient loss of consciousness. So there was no one there to say, yeah, they were seizing, convulsing, flailing their arms. You don't really know. You can't confirm that they had a seizure because there was nobody there to say they did, to witness it. Because a serum lactate, if it's elevated in the first 2 hours after the event, essentially this confirms that it was a generalized seizure rather than some other cause like a syncopal episode or a psychogenic non-epileptic seizure. Serum prolactin is another lab you may have heard about, but it's not as sensitive or specific as lactate, and it's not usually recommended as part of the routine evaluation. But remember serum lactate, because that one is going to be important for you to know. It may come up. Definitely when you're out in clinicals, it's good to know about these extra tests like that. Neuroimaging is another big thing. You definitely want to shoot for your MRI rather than the CT. So in a patient that has their first seizure, you have to get some kind of imaging of the brain because you want to rule out any abnormality like an intracranial neoplasm. Again, MRI is going to be preferred, but CT is an alternative. And then finally, the one that we kind of associate with seizures, and that's going to be your EEG, your electroencephalogram. And once you've ruled out your vitamins, you find out this wasn't a vascular cause, a stroke, an infection, toxins, etc. You want to get your EEG. So it's not 100% sensitive, but the thing is, if it is abnormal, it can help support the diagnosis of an epileptic seizure, and it can help you distinguish between generalized or focal seizures. In general, there's not a lot to know about the specific findings for EEG, except for one thing. So if you see on a vignette that they mention a 3 Hz spike in wave pattern, right away you should be thinking of absence seizures. I definitely got this question. You probably will too. Don't worry about why so much because you'll just waste your time in kind of understanding it. Just know if you see a 3 Hz spike in wave pattern in a vignette, the answer is absence seizure. So right away you should be thinking that if you see that. So again, for your diagnostic studies, remember 3 things: neuroimaging, again MRI over CT if you can, your labs, checking electrolytes, blood glucose, and then your EEG. Those are the 3 main ones to focus on. Let's move on to treatment. So I just wanted to talk about this real quick before we start. So with anti-epileptic medications, there's really no first-line meds. Quoted from UpToDate, no single anti-seizure medication is clearly the most effective or best tolerated. So they're generally not going to give you like a list of 4 or 5 seizure meds and say which one would you pick, which is the best. There's exceptions I'm going to go over, like with absence seizures, but the most important thing about anti-seizure meds is knowing their specific adverse drug reactions, because they could ask you something related to that. So not so much about which med is going to work best to prevent this patient's seizures, but maybe which med is going to be safest considering this patient's comorbidities, things like that. So most patients with their first seizure, they're not going to require anti-epileptic medications. The patients that you're going to start on anti-epileptic medications are patients with 2 or more seizures, because by definition they now have epilepsy and that generally does need to be treated, or if this is their first seizure and then they're at high risk for a second. So high risk, like I talked about before, meaning a brain tumor, stroke, head trauma, abnormal neuro exam with focal findings, abnormal EEG. These are all high-risk findings, and in these patients, it would be acceptable to start them on meds, even if they've only had one seizure. And then the final thing, obviously, if they wind up going into status epilepticus, these patients are going to get started on anti-epileptic meds. That can be, terrible. You don't want them to have a recurrence of that. So let's first go over the two types of seizures where there is a specific first-line therapy. There's only two instances, so let's go over that first, and then we'll go over the general meds next. So the two types of seizures you need to know a specific medication regimen for are absence seizures and status epilepticus. So let's start with absence seizures. This one you definitely need to cement in your brain. So absence seizures, the medication that you need to know is ethosuximide. You have to know that one. That is first-line treatment for absence seizures. Second line, and I don't always recommend knowing second line. I'm only saying this because I got asked it, so I feel like you probably should know it. So valproate is going to be second line. So know first and second line. And the way that you're going to remember this is by remembering this little sentence here. So hopefully you've heard the expression vanish into the ether. Like when something vanishes into the ether, it's like gone, it's absent. So vanish into the ether. So absence seizure or absent seizure helps the mnemonic. So absent seizure, again, first line is ethosuximide, second line is valproate. So you remember the sentence, as soon as you see absent seizure, think of being absent. And when you're absent, you're gone, right? You've disappeared, you're absent. So when you think when you're absent, into the ether, you will vanish. When you're absent seizure, into the ether, you will vanish. And that sentence is in order because ether comes first, and ether is the first three letters of ethosuximide. And then vanish, the second word, so second line treatment, is the first two letters of valproate. So if you can associate absent seizures with being absent, into the ether you vanish, you can remember the first and the second line treatment for absent seizure. So remember that when you're absent, into the ether you will vanish, ethosuximide first line, second line valproate. All right, second one that you need to know, status epilepticus. Remember, a seizure that goes on too damn long, that's status epilepticus. So there's a few lines here. So first line, benzodiazepines, first line. If you don't remember anything else for status, remember benzos. They're the main treatment, the best because of the rapid onset. And the three most commonly used benzos are going to be diazepam, lorazepam, and midazolam. So lorazepam is usually preferred, but you can use any one of those. So with benzos, you give them their first dose, then you reassess in about 5 to 10 minutes. If they're still seizing, you hit them with another round of benzos. And if they're still seizing, in addition to getting a neuroconsult and EEG, you're going to ramp up the meds, and then next in line, we'll talk about the second line in a second. I wanted to mention one other thing with benzos. A lot of times you will add another anti-seizure medication to it. Sometimes it's valproate or something else, but I just wanted to mention that in general. I don't think you're going to ask you that on the boards. Just focus on first line is going to be benzos. And then your second line, if benzos weren't working, you gave them a couple rounds of benzos, nothing, they're still seizing, then you have to ramp it up. And generally your phenytoins, your phospheniton, your phenytoin is going to be your second line. There are some other options, levetiracetam, which is Keppra, valproate's another one for your second line, but generally on the boards, on your exams, they're going to be asking you about phenytoin, will be your second line. And then if that's not working, you've tried your second line meds, your phenytoins, they're still seizing, then you go to your third line medication. So if they're still seizing at this point, they have to be intubated, they have to be on mechanical ventilation. As far as treatment, you do have other options, but pentobarbital is usually the one you'll see tested on. This is really like your last option. You've tried everything else. Their brain's cooking, you need something, and that's when you'll use pentobarbital. Some guidelines will suggest propofol, continuous infusion with midazolam. At this point, you're basically putting them into a drug-induced coma to save them. But again, for the boards, focus on your third or last line as pentobarbital. That's usually what's going to be tested on. So remember those three lines. Just as an FYI, you may have heard of phenobarbital being used for status, but pentobarbital has actually replaced it due to being more efficacious. It has faster brain penetration, shorter half-life. So that's your first, second, and third line treatment. So how do you remember that? So for status epilepticus, really, if you just focus on benzos, you'll probably get the question right, as that's normally what they ask on, particularly because when you get to second and third line, there's some options, but generally this is the way to remember it. Benzos, phenytoin, pentobarbital. So the way that you remember that is you remember a guy named Ben. So status epilepticus, as soon as you think that, as soon as you see that, status epilepticus, I want you to think of, he had to update his tetanus status when Ben caught his toe in some barbed wire. So as soon as you see Statusepilepticus, I want you to think of this guy's tetanus status. He had to update his tetanus status when Ben caught his toe in some barbed wire. So this is all in order here. Tetanus status, Statusepilepticus, when Ben, because that's benzodiazepine's first part of the sentence, that's your first line treatment, caught his toe in, that helps you remember phenytoin, and then some barbed wire. He caught his toe in some barbed wire is your pentobarbital. Remember this sentence. He had to update his tetanus status because Ben caught his toe in some barbed wire, and you will remember the first, second, and third line treatment for Statusepilepticus, and you'll get the question right. Okay, let's move on. Those are the ones that you needed to remember because those are the ones that have those specific guidelines, specific first and second line meds, etc. Now with the rest of the meds, they're not really going to ask you again, like I said before, to pick the best med because there really isn't one. It's basically you considering the contraindications for the meds, the cost, etc. It's very individualized, and really it's going to be up to a neurologist to decide. But let's go over some of the more common meds. We'll go over a few mnemonics and things you should know for each, because there are some pretty high yield ADRs, some high yield adverse drug reactions with these. So those are the main things that you need to know. So let's start with carbamazepine. So carbamazepine, it's a good med for both focal and generalized seizures. Can cause Stevens-Johnson syndrome, like almost all anti-epileptic medications, and I do have a way for you to remember all of the Stevens-Johnson syndrome meds at the end. But the indication that you need to know for carbamazepine, because it's the one that it's first line for, and again, you should know your first line meds, at least most of them, and that's going to be trigeminal neuralgia. So this is a first line med for trigeminal neuralgia. Second thing that you need to know, because sometimes they'll ask about the MOA, is that it blocks sodium channels. And then the third thing, you need to know that this increases your LFTs, your liver function tests. It's hepatotoxic. So three things that you need to know for carbamazepine. Trigeminal neuralgia, this is the first line med for it, blocks your sodium channels, and it increases your LFTs, your liver function tests. How do you remember that? So you remember, lift up some salty carbs like the fries this guy's eating, and chew on them till your cheeks hurt. So what this means is as soon as you see carbamazepine, you think of carbs, and you think of lifting up, so you lifted up these carbs here, some salty carbs, and chew on them till your cheeks hurt. So lift up, there's no I there, but the LFT up, because remember your LFTs go up, hepatotoxic, your liver function tests go up, so lift up, that's your hepatotoxic. Some salty carbs, so salty because remember it blocks sodium channels, helps you remember that. Carbs, carbamazepine, and chew on them till your cheeks hurt, because remember what trigeminal neuralgia is. Trigeminal neuralgia is the pain that you have in your face from the nerve being affected. So that's how you remember the three things that you need to know about carbamazepine. As soon as you see it, think of your salty carbs, lift up, hepatotoxic, some salty carbs, where your LFTs go up, some salty carbs, salty, block sodium channels, carbs, carbamazepine, chewing them till your cheeks hurt, first line med for trigeminal neuralgia. That's carbamazepine. If you remember that, you'll probably get the question right. Second med that you should be familiar with, valproic acid, also known as valproate. So this is a broad spectrum anti-epileptic med, very commonly used. It's really effective for both focal and generalized seizures. Also, I know there's not really any first line meds outside of the exceptions we talked about, but in some literature for juvenile myoclonic epilepsy, like a very specific type, they do consider this a first line med. Those are all just FYI. I don't think that's stuff you're going to be tested on. That's again more for neurologists to decide. Now for adverse drug reactions, this is the important stuff. So there's a few key things you need to know about it. Again, mainly it's adverse drug reactions. That's what you're going to be tested on, so focus on these. So first thing, I was tested on this, so you do need to be aware of this. So most anti-epileptic drugs are teratogenic to an extent, but valproate by far is the worst, and it's associated with the highest rate of teratogenicity of all the marketed anti-seizure medications. I feel like I said that weird or wrong. Anyways, you know what I'm saying. So it's the worst of all of them. Pregnant patients should never take this one. This is the one you absolutely have to avoid in a pregnant patient. So this has the highest rate of teratogenicity of all of the anti-seizure meds. And that's why it's the one they're going to test you on. They're going to give you a pregnant patient, ask you which med you should avoid, and it's going to be valproate. So you have to know that this one is teratogenic. Second thing that you need to know, pancreatitis. In real life, it's not that common, but for some reason it's often tested on. So remember, acute pancreatitis is a possible complication of valproate therapy. And then finally, remember, this is hepatotoxic. It can cause an acute hepatocellular injury. This is usually within the first 6 months of starting valproate. Some cases, it can actually be associated with fulminant liver failure and death. So definitely need to know that. Three things you need to remember for valproic acid. Three things that are generally tested on: pancreatitis, hepatotoxicity, and that it's teratogenic. How do you remember that? You remember valproic acid, VPA. V stands for vertical transmission. To help you remember, it's teratogenic. Now, I know what vertical transmission means. I know that it generally means that there was some kind of pathogen going from the mother to the baby. That's not what this is, but it helps you remember kind of the idea that this patient's taking a med and it's affecting the baby, kind of like going through that vertical transmission. So again, that doesn't exactly mean teratogenic, but it helps you get there to remember that this is the worst of all the anti-epileptic meds. So V in valproic acid stands for vertical transmission, teratogenic. P stands for pancreatitis, and then the A in valproic acid stands for acute hepatocellular injury. Those are the three things that you need to remember. Moving on to phenytoin. So this drug's been around since the 1930s. We're still using it today. It's a good med for focal and generalized seizures, for Statusepilepticus, as you know. It's the second line after benzos, like we went over with the mnemonic. There's a laundry list of ADRs from phenytoin, but the important ones, the main systemic side effects that you need to remember are these three. So remember hirsutism, which is excessive hair growth in women. Remember gingival hypertrophy. It's an abnormal overgrowth of gingival tissues. And remember folic acid depletion. It inhibits folic acid absorption. Now, I'm not just generally, because again, like I said, there's a lot of ADRs. I'm not just kind of picking these to make my mnemonic work. I'm picking these because these are the ones that I've always heard about in school that were always tested on. So again, there's a lot. There's probably like 10, 15 that you could remember for this, but these are the three that always seem to come up. So the way that you remember this for phenytoin is you remember this disgusting picture here. So when you see phenytoin, I want you to think of putting a toe in your mouth. So if you put a hairy toe in your mouth and lick it, you'll get gingivitis. If you put a hairy toe in your mouth and lick it, you'll get gingivitis. So if you put a hairy helps you remember hirsutism, toe in, that helps you remember phenytoin, your mouth, and lick it, that helps you remember folic acid depletion, you'll get gingivitis. Gingivitis helps you remember gingival hypertrophy. So again, as soon as you see phenytoin, think of putting a hairy toe in your mouth, and you think of putting a hairy, hirsutism, toe in your mouth, and lick it, folic acid depletion, you'll get gingivitis, gingival hypertrophy. Those are the three things you need to know for that one. Those are the main ones that you need to know. Those are the ones that I would focus on. That's the ones that have the most unique ADRs, the ones that they always seem to test on. A couple other ones we'll go over. We went over this. This is just a duplicate, but I just wanted to bring it up again. Remember, ethosuximide blocks calcium channels. And then, of course, the most important thing here is that it's first line for absence seizures. Really remember that. That's probably the only thing you need to know for this drug. It's very narrow spectrum, so it's really just for absence seizures. Remember that. Don't forget it, because when you're absent into the ether, you will vanish. And then also it can cause Stevens-Johnson syndrome, which again, we'll go over mnemonic at the end to help you remember that. Next one, pentobarbital. Really the only thing I would remember for this is that it's last line treatment for Statusepilepticus. That's important after phenytoin. That's about all I would know for that. So just a few other meds. Levetiracetam, such a hard one to say. That's why we always call it Keppra. It's another broad spectrum anti-epileptic med, commonly used because its side effect profile is pretty favorable compared to some of the other options. Doesn't have as many adverse drug reactions compared to some of the other meds we went over, and therefore not a lot to test on about it. So nothing specific I would say to know for it, just that it exists. Some other ones that you may hear of, but nothing specific I would know for these: lamotrigine, topiramate. Those are just some other options, just not a lot of high yield stuff to know for them. So I didn't cover every anti-epileptic medication. There's over 25 of them, so that'd be crazy to cover them all. But again, I focused on the high yield ones, the ones that have unique ADRs and the ones that are often tested on. So one last tip, nothing crucial that I think you have to know for seizures specifically, but good overall knowledge for the PANCE, for something that does come up from time to time. So most anti-epileptic meds can cause Stevens-Johnson syndrome. So Stevens-Johnson syndrome, if you're not familiar with it, it's the severe mucocutaneous reaction. It's most commonly triggered by medications. It can cause necrosis, detachment of the epidermis. It can be pretty serious. And again, most anti-epileptic medications can cause this. There's some non-anti-epileptic meds that can cause it too, which is going to be included in this mnemonic. So it's fairly important to know these meds and classes because you'll probably get a question on it at some point, and this is how you remember them. So remember Stevens-Johnson syndrome. The first few letters of that is the first few letters of Steve Jobs. And Steve Jobs created Apple PCs. So as soon as you see Stevens-Johnson syndrome, if that helps you remember Steve Jobs, you can remember Steve Jobs created Apple PCs. And Apple PCs stands for allopurinol, phenytoin, phenobarbital, lamotrigine, ethosuximide, penicillins, carbamazepine, and sulfonamides. Those are all capable of causing Stevens-Johnson syndrome. That's not every single medication that can cause Stevens-Johnson syndrome, but those are the main ones, the ones that most commonly cause it and the ones that you'll probably get tested on. So remember Stevens-Johnson syndrome, remember Steve Jobs created Apple PCs, and then remember those medications there. So that's the last thing that I wanted to mention before we move on to 5 quick questions to see what you remembered. So first question. A 9-year-old male presents to the office accompanied by his mother. His mother states that the boy has had frequent episodes where he will zone out and stare off into space for a few seconds multiple times per day. The mother states the boy is unresponsive to her voice or tactile stimulation during the episodes. The patient has an EEG performed during one of the episodes in the office, which displays a generalized 3 Hz spike in wave appearance. What is the first-line medication for the likely diagnosis in this patient? So it shouldn't be too hard because I told you there's not many first-line meds to begin with, and then you get that 3 Hz spike and wave. It's a child staring off into space. This should be very easy for you to remember. So it's ethosuximide. Patient has classic findings of an absence seizure, so sudden impairment of consciousness, lasting seconds, occurring multiple times a day. In addition, we have the classic findings on EEG, which I told you was those 3 Hz spike and wave pattern. First-line treatment for absence seizures is ethosuximide. And remember, when you're absent into the ether, you will vanish. So if I ask you the second line med, you know that too, because you remember vanish, second word in that sentence, and that's for your valproate. Okay, question 2. 64-year-old homeless man is brought into the emergency room by fire rescue. The paramedics state he has been actively seizing for the entire ride over, which has been over 15 minutes. On physical exam, you note rhythmic jerking of the bilateral extremities. What is the first-line medication class that should be initiated in this patient? So that is going to be benzodiazepines. So this is Statusepilepticus by definition. Remember, it's defined by either a single seizure that lasts over 5 minutes, which in this case it did, or they have more than one seizure without recovery between each episode. Patient meets the criteria. He's been actively seizing over 15 minutes. So the first line med for Statusepilepticus we know is benzos. So that's going to be diazepam, lorazepam, midazolam. Lorazepam generally being preferred, and if that doesn't work, we know the next line is going to be our phenytoin, and finally pentobarbital. So remember, he had to update his tetanus status when Ben caught his toe in some barbed wire. All right, question 3. Which type of generalized seizure is described by sudden muscle stiffening, often associated with impaired consciousness? So remember, sudden muscle stiffening, that's going to be our tonic seizures. And remember, a gin and tonic is a stiff drink. Question 4, which anti-epileptic medication works by blocking sodium channels and is first line for trigeminal neuralgia? So that is going to be carbamazepine, and you can remember the mnemonic, carbamazepine, lift up some salty carbs and chew on them until your cheeks hurt. So LFTs go up, hepatotoxic, salty carbs because it blocks your sodium channels, and your cheeks hurt because this is first line med for trigeminal neuralgia. Question 5, last question, what is the most common type of generalized seizure? So that is going to be your tonic, clonic, or grand mal seizure. Remember, it starts with the tonic phase, all the muscles become stiff. Then after a minute or two, the clonic phase begins where the muscles begin to jerk and twitch for an additional 1 to 2 minutes. All right, so that was seizures. Hopefully that was helpful. Thank you so much, as always, for listening and all the really nice comments. And good luck in PA school. Good luck on your PANCE, your PANREs, your EORs.